We have Timothy Wong, who is going to be presenting this abstract about integrated community case management, iccm, during the COVID-19 pandemic, a descriptive study of MSF experience in Kenema project, Sierra Leone. So Tim, thank you so much. The floor is yours.
Thank you, Anna. Hello, everybody. Good evening, good afternoon, good morning, depending on where you are. I'm Tim. I am a medical doctor from Hong Kong, and I was in the gorama, mende, wandor project of OCB in Sierra Leone. Sadly, the project is now only half functioning because we are reaching our closing stage, but we are presenting this on behalf of the entire medical department. With special thanks, of course, to the community health workers, the nurses, the health promoting team who are doing the field work on a day in, day out basis during these very difficult times. Next slide, please. So an introduction to iccm for those of you who might be a bit less familiar. It is a strategy endorsed by WHO and UNICEF to increase healthcare access, predominantly for children in resource-limited settings in communities who may be living far away from facility-based care. Through the use of community health workers, who are usually volunteers selected from the communities they serve and trained to recognize and treat three main conditions of childhood. So pneumonia, malaria, and diarrhea. And in some implementations, including that of Sierra Leone, the community health workers also screen for malnutrition. Next slide, please. So in view of COVID-19, the WHO recommended that the governments, including the Ministry of Health and Sanitation in Sierra Leone, adopt a so-called no-touch policy. This is actually a reiteration of a policy that was in place in Sierra Leone during the 2014 to 16 Ebola outbreak. And, but then if you look at the existing literature, the impact of this no-touch policy on iccm activities and the diseases they treat has not been very well documented. Really, there's a lack of appropriate PPE in settings such as the one we were working in, and the aim was to reduce contact between community health workers and patients, and therefore avoid or slow down at least community transmission. For the purpose of our project, we were looking mainly at malaria, and if you look at the yellow box, you can see that before the no-touch policy, the recommended test is to do a rapid diagnostic test. If the test is positive for malaria, the community health worker will give treatment. But then after no-touch policy, then RDTs are not done, and anyone presenting or complaining of a fever, regardless of whether they actually have a fever or not, is given presumptive treatment for malaria. Similarly, there were changes in how pneumonia and malnutrition was being assessed. Next slide, please. So initially, this was a project needs assessment more than a real proper study, but we were trying to assess the impact of the no-touch policy on rapid diagnostic tests and anti-malarial use. We are trying to describe the community health workers' perceptions, the changes brought on by COVID-19, and also to describe the impacts of no-touch policy and COVID-19 on the patient populations. Next slide, please. So the method we used was a retrospective analysis of data. We were collecting data at both the CHW level and PHU, which is the clinic level. At the PHUs, they were not affected by the no-touch policy, so they continued to do rapid diagnostic tests for patients presenting with fever. And we did very basic statistics to look at the use of antimalarials and the use of RDTs before the NTP and after the NTP in the 2 months immediately before and the 2 months immediately after. We also did a qualitative analysis of the community health workers' experiences and perceptions, and we collected these during routine monthly CHW meetings we have with them anyway. Next slide, please. So if you look at the results, the quantitative aspect, the percentage of CHW consultations that resulted in anti-malaria prescription notably increased from 67.3% of consultations to 76.5%, which is 9.2 percentage points. This is quite a large number and quite unexpected, especially if you compare it to the figures we obtained from PHUs during the same time frames. There was not a significant increase in the use of antimalarials. And similarly in 2019, if we look at the same 2-month intervals, there was also no such difference, which we are using this as a proxy to suggest that the incidence of malaria has not really been changing that much to explain this increase in the use of antimalarials. Next slide, please. So in terms of the qualitative element, we did the thematic analysis and came out with 3 themes. Firstly, there was an impact on the service. The CHWs in general reported feeling more protected and safer because they did not have to touch the patients and they stood further away from the patients. But they also admitted that patient assessment became more challenging. And to them, a lot of them were worried about whether they were providing appropriate treatment, especially given that they were not doing a rapid diagnostic test. So they really could not know whether the child actually had malaria or not. The second theme, community reactions as experienced by community health workers. These were mixed. There were some negative reactions in that some members of the community felt that they were being treated unfairly and were not being offered RDTs because they did not understand why there was suddenly this policy in play. But then there were also some positive reactions among those who understood a bit more about the COVID-19 situation because they felt there was less interaction and therefore they felt safer. Thirdly, it was really a supply issue. There was evidence that there was stockouts of antimalarials before the next month's supply, and neither MSF nor the ministry was able to supply additional stocks of antimalarial because I guess people did not expect this change in use. Next slide, please. The limitations of our study really is that we use retrospective data. A lot of the data was not, when we collected the data, it was not really for this purpose. So we also had to make a lot of assumptions and we had to use a lot of proxies that may or may not have been suitable. The quality of the data sometimes is a bit dubious and may not be fit for purpose, as I said. And we also probably had a lot of bias going into how we recorded the important so-called information from interviews. And I believe this would limit the generalizability of our findings outside the general concepts that I will present in the next slide. Really, we wanted to see whether COVID-19 would affect patient attendance and also things like hostility towards health workers, because these are issues that have been experienced and documented during or immediately after Ebola. But unfortunately, we found that we did not have adequate data to show any of this. And because of the nature of the project being closed, we also did not have sufficient resources to embark on a study to do that. Next slide, please. So finally, in terms of conclusions, I think we can definitively say that there are some visible impacts of COVID-19 and associated policies on child health and programs. Within our particular setting, we can be quite confident that some children have been prescribed unnecessary antimalarials because not every child with fever has malaria. We were having, like before that, something between 60 to 80% positive rate in terms of the antimalarial tests we do. The end effects of not doing RDTs and antimalarial stockouts, they need further studies and could not be assessed by our particular data. And also, we also wanted to look at the impact on, say, pneumonia, for instance, given that they might have similar presentations to COVID, but unfortunately, again, we don't have any data to present on this front. And as we all know from the previous session, there are concerns about AMR or masking or delayed treatment, particularly relating to the use of antimicrobials for pneumonia. Secondly, CHW's concerns are often underexplored. We do not see a lot of studies who doing research in this field, and even their concerns are sometimes probably difficult to address. We know from previous studies done by MSF, including the trust in healthcare providers and facilities is fragile, and this is the importance of health promotion activities, especially on how the community understands COVID-19 and the need for a no-touch policy, and also it also relates to anti-malarial prescriptions and antibiotics and all that as well. Healthcare workers can be underpaid or unpaid, and they are sometimes just incentivized. So it's also important to keep their interests in mind. And finally, I guess the other thoughts we had was that it is particularly important to understand the impact of the no-touch policy in projects such as ours, because we were working in Lassa fever endemic area. We had the Ebola in 2014 to 16, and we also recently had Ebola in Guinea, which is right next door. So we can assume that similar no-touch policies might be in play after COVID or might be reintroduced at some other point, and we really should understand what impact these policies may have on projects such as iccm. And also, I think in terms of research in MSF projects, there is a lot of it. Throughout the entire 2 days, we have seen a lot of it. But then for our project, for instance, when we started asking certain questions, we found that we really didn't have the routine data to answer all of them. And that's something that we might be thinking about in the future. So yeah, that's the end. So thank you, and